So now I will pass the baton back to Steve to talk about patients, right?
Right. So now that you guys have an excellent foundation, we're going to try and put this into practice with a couple of cases. We have 4 cases that we'll try and get through, so we might not get to all 4 of them, but let's see how it goes.
Thank you.
All right, the first one, 63-year-old gentleman with combined pulmonary fibrosis with emphysema. He presented with worsening shortness of breath, admitted via the ED, and he had a CT that was consistent with CPFE. On exam, he had crackles bisally, nothing really to suggest pulmonary hypertension on his cardiovascular exam, or no peripheral edema either. This is him. Let's look at his PFTs. So he has an FVC of 59%, FEV1 58%, not obstructed, which we see most of the time in CPFE. They're not necessarily obstructed. So he has moderate restriction, and his DL is only 18%, so disproportionately reduced. And we'll come back to that. He's walked on 6 liters, so he requires a good amount of oxygen. And despite this, he can only walk 96 meters and desaturates to 85%. So very compromised there. Gets very short of breath with a Borg of 6. Pulse rate recovery is only 2. And his BMP is kind of just borderline on the low end of the upper threshold. So you've seen this before. Jean showed this in her presentation. All the clues potentially that could tell us maybe this patient has pulmonary hypertension. So which ones are relevant in this case? And outlined over here: low walk distance, increased desaturation, low pulse rate recovery. Pulse rate recovery, for those of you who don't know, is what's the pulse rate at the end of 6 minutes and then 1 minute into recovery. So if they go up to 120 and then they're still at 110, 1 minute into recovery, pulse rate recovery is 10. So the lower the pulse rate recovery, the worse. His was 2 or 3, so very low pulse rate recovery. And then the other thing you might have noticed is the FVC was pretty well maintained, but the DL was kind of in the toilet. Clearly the ratio well beyond 1.5, 1.6. The higher the ratio, the more likely that there's underlying pulmonary hypertension. So here we come to a question for you guys. What evaluation should be performed to further examine this patient? A CTA, a transthoracic echo, right heart cath, or all of the above? And what do we have here? So 50% say all of the above, 34% say right heart cath, 16% say echo. So probably the best answer is all of the above, 50%. It's not to say that right heart cath is incorrect. Certainly this patient does need a right heart cath. Echo is not, it's also included in all of the above, but probably all of these would be best in this particular patient. So this is the CT. You don't see the bullous disease too well in these images, but clearly fibrotic changes at the bases. And this was a CT when he was admitted to the ED. And here we have the echo. So echo was obtained, the RVSP 81, normal left atrium. So that's good to know because it makes it less likely that there's a component of group 2, normal EF. And so certainly more evidence that there's underlying pulmonary hypertension. I always also look at the right atrium and the right ventricle mildly dilated. That is also a further supportive evidence. And here we have the right heart cath, mean pulmonary artery pressure 26, wedge is normal, and the PVR is 3.5. I have to say, in this case, if you had asked me a priori, I would have guessed probably higher than this.
Yeah.
So, but certainly qualifies as having pulmonary hypertension by the new definition and by the old definition and by the pre-2018 definition.
But I think, Steve, what it also shows us is that there's a difference between the estimated pressures on the echo and the more correct pressures measured by the right heart cath. It is both tests show pH.
Yeah.
However, the degree of pulmonary hypertension was probably a little overestimated by the echo, and that's why it's important to do the right heart cath.
No, you're absolutely right. The echo said 81.
Exactly.
And here it's 50. So a lot of times you do see the overestimation.
Yeah.
Yeah. Good point. Okay. So next question. What is the diagnosis for this patient? Heart failure, thromboembolic disease, infection, or PH due to ILD? 97%. Excellent.
All right.
Great
Good.
job, guys.
Yeah,
Yes.
sure. If that was below 50%, we would have had to start at the beginning, I have
Yes.
to say. So you guys saved yourselves. Next question. What therapy can be considered for this patient? A, inhaled treprostinil, B, ambrisentan, C, riociguat, PD-5 inhibitor, or E, none? 98% inhaled treprostinil, 2% Rio. Who's that person? I'm kidding, I'm not going to single you out. Someone hit the button incorrectly. Okay, so Rio we know is contraindicated because the PVR was 3.5.
Yeah.
And it seems, for some reason, that some people believe that patients with PVRs of between 3 and 4 shouldn't be treated. I think this might be more of a prevailing sentiment over the pond in Europe, because if you look at the recent guidelines from the 7th World Symposium, there's a little bit of equivocation about 3 to 4. Jean, would you care to comment on that?
So the way I approach these patients is I treat them as they were treated in the INCREASE trial. So I would treat the person.
Agree. Ioana, any?
Yeah, I agree. Yes, the PVR over 5 is usually associated with worse prognosis in group 1 PAH. We don't know exactly. I mean, we do know that the worse the PVR, the worse the prognosis, even in this subpopulation. So we know the PVR over 3 is for sure disease. We have a treatment. I would not withhold.
I agree, and I think one of the things, just to go back, I think Jean, you showed the slide from the Spanish registry where any pulmonary hypertension,
Yes,
even
exactly.
mild or borderline, portends a worse outcome. So I think the thing that we have to realize and divorce is that mild pulmonary hypertension doesn't mean mild disease. Mild pH in the context of ILD is severe disease because those patients also have a dismal prognosis.
Yeah, and we don't know if we impact survival in milder patients, but we may as well try to impact how they feel and how they function, right?
Certainly.
Improvement in exercise capacity, it usually helps them go through the day, right?
All right, I think those points might come up in these other cases, so we'll move on to case number 2. Here we have a 65-year-old male, worsening shortness of breath, requires more oxygen on exertion, uses up to 5 liters going up hills. He has a diagnosis of IPF based on the UIP pattern on his HRCT, and he used to walk daily, worsening over time. So this is someone with IPF with worsening symptoms and seemingly increasing oxygen requirements. Let's look at his PFT. So his FVC is just under 50%, so borderline severe restrictive physiology. His DL is 52%, so kind of reduced proportionate to the FVC. Mm-hmm. He does walk on 4 liters. He desaturates to 83. His distance is low, but not too bad, 388. His Borg is also 6, and his pulse rate recovery is 14. His BMP is low or in the normal range at 11. And here we have his CT. You can see fibrotic changes at the bases. As we get up towards apices, he still has subpleural reticulation, but actually not too bad. And here we have mediastinal cuts shown for this reason. The PA is not too big. You can look at the PA in relation to the ascending aorta, and the ratio is clearly less than 1. So this doesn't necessarily indicate, but doesn't rule out pulmonary hypertension. Get the echo, RVSP 31, and nothing really much else there to suggest pulmonary hypertension. So let's get the right heart cath.
The one thing
you want to go
that,
back?
Yeah,
Sorry, before we...
No, you can put it. The ascending aorta is enlarged.
No, it's a good point.
Yeah.
So just so that you know, Ioana's point's well taken, so there could be a little bit of an aneurysm there, but the upper limits of normal of the diameter of the PA should be around 30 millimeters, so you can always measure that out. Here we have the right heart cath, 38/13, MPAP, surprise, surprise, 27, actually a little bit higher than that other patient. The wedge is 14, so right on the border, and the PVR is 2.2. Interesting. So, doesn't qualify for the pre-2018 definition, wouldn't have qualified for the INCREASE study, but certainly does meet the new definition for pulmonary hypertension. What is the diagnosis for this patient? Okay, get your phones out again. Is it A, heart failure, B, venous thromboembolism, C, severe PH due to ILD, or D, mild borderline PH due to ILD? All right, and here we have 93% mild borderline PH due to ILD. That is correct, very good. We're making an educational impact here. Well done, nice. Okay. Yeah, it's an interesting case in terms of what you do with that patient, and we couldn't get inhaled treprostinil because insurance companies are going to kick it back, and it's a tough question, unknown answer. Do you follow the patient? Do you repeat the right heart cath? When do you repeat the right heart cath? Gene, you showed progression over time. What would you recommend to this patient, Ioana?
Well, let's ask the audience first, and then, because I think we have a question.
Oh, there's a question?
Yes, there's a question coming.
Okay,
let's ask the audience first.
Okay.
Here you go.
Gosh,
What
you're
would
right.
you do?
You know the slide deck better than me. Okay. So we have another question. What therapy can be considered for this patient? I gave away that, okay. Sorry. A, inhaled treprostinil, B, ambrisentan, C, Rio, D, PD5, or E, none. Okay.
Okay.
That's interesting. So the way the question's phrased, and there's some good question answer, people here have taken a lot of exams because can be considered is different, should be implemented. So certainly I think inhaled treprostinil can be considered. Ambrisentan, no. Rio, no. PD5 can be considered, and certainly none can be considered because this is a group that hasn't been studied. But just to go back to, sorry, if we can go back to this slide that Jean showed already. The top is baseline, the bottom in yellow is follow-up right heart cath. The curve is shifting to the right. These patients are going to progress. Not everyone progresses at a rate of 1.8. That's the average for the group. My own personal bias is that the more vasculopathy there is, the higher the rate of progression. And not every right heart cath we're going to get is going to show treatable pulmonary hypertension. But then what do you do with that patient? It's not a one and done deal. And this is someone that really needs to be followed more closely. And which brings us to the next patient. And
let's go back because that's a very interesting patient that I'm sure you have in clinic. It's right at the border. And I think one approach is to discuss with the patient. If they feel very limited, I think it's worth trying. But also because of this area where we don't have a whole lot of data, it's very reasonable to stop the treatment if you don't notice any improvement. So a trial, a treatment trial, I think it's very reasonable if the patient is interested.
Yeah, certainly if you can't get the one paid for, you have things like sildenafil, which are generic. I'll give you an anecdotal case that I had about 18 months ago. 75-year-old gentleman, IPF, desaturating, very similar to some of the cases we showed. I thought he had pulmonary hypertension, got the right heart cath, PVR 3.5, MPAP 24, not 25. Put it in for insurance, kick back, no. They wouldn't pay because there's an administrator who's checking the boxes and 24 is not 25. So I can't remember if I put him on a little bit of sildenafil or not, but he continued to get worse, and 9 months later repeated the right heart cath. The mean PA pressure was 55. And we put him in for inhaled treprostinil, but unfortunately he succumbed a month after that. So it kind of made me question my own management. Should I have gotten the right heart cath 3 months afterwards? It's hard to talk to a patient and say, you just had a right heart cath, let's get another one. Probably could have got 26 or 27 even 2 weeks afterwards. So just an illustrative type of case we have to deal with.
And I think the message is that this is not a one-stop visit and diagnosis. You have this borderline or mild pulmonary hypertension. You have to see them back. You have to reevaluate. You have to do an echo and a walk and a BNP because it could go very quickly at times.
Absolutely, yeah. All right, which brings us to case number 3. I think this is yours, Jean.
Yes, thank you. So I'm going to present a 71-year-old male, and he's having worsening chronic cough, and you're evaluating for transplant. He has a diagnosis of IPF, and it was made by biopsy. And he does have some past medical history, diabetes, hypertension. He is on oxygen, and he's on antifibrotics. So very similar to many of our ILD patients we see. All right, so now some data. And I want you to crunch this and put it into that algorithm we talked about earlier. So as I said, he's getting worse. You look at his pulmonary function testing, and his FVC is 56% predicted, and his DLCO is 16% predicted. So unlike the last case, this is a disproportionately low DLCO. In terms of his walk distance, he is walking 313 meters, so much better than the last patient. He's desaturating to 91%, and he's on room air. So doing a little bit better in terms of oxygenation. But his BNP is elevated to 226. So trying to incorporate all of that data into your workup and trying to determine what you think is making him feel worse.
It's actually, Jean, one thing that's notable there, I just saw, he has a negative pulse rate recovery. So 1 minute into recovery, he was actually more tachycardic than at the end of the study.
Very true, very true.
Yeah.
So if you think about yourself when you exercise, your heart's pounding really hard, and then you stop, rest, and your pulse comes down pretty darn quick if you don't have any medical conditions. But these people, I mean, you can almost feel their discomfort because they do not recover quickly. They have to sit there after their walk distance is assessed in clinic for 5-10 minutes before they can move to their exam room. So he does get a repeat HRCT chest, and clearly he has interstitial lung disease, IPF, which he's been diagnosed with by biopsy. So what's your suspicion based on what you saw? The high BNP, the low DLCO, the low heart rate recovery. Do you have low suspicion, high suspicion, no suspicion, or you need more data? All right, good, good. So we want a little bit more information, some of you, which is important, but many of you are concerned about pulmonary hypertension. What about you guys?
Yeah, absolutely. The DLCO that is that low, in and out of itself, it makes me trigger the idea of pH.
So is DLC the biggest driver for in your mind too, or what else would be in what you've seen?
In this particular case, I was impressed by the negative pulse rate recovery. I think DL is a big driver. The lower the DL, the more likely.
Yeah.
But it gets to the point of we don't want to miss it because it's a therapy we can offer. And the question I always ask myself is when we do send patients for right heart cath, what's the appropriate hit rate? Should it be 30% have pulmonary hypertension? Should it be 50%? It certainly shouldn't be 100% because if 100% of the patients we're sending have pulmonary hypertension, then you know you're missing a whole bunch.
Exactly. You've got to be wrong some of the time.
Yeah.
And not all the tests are easy to be performed. If they're on a lot of oxygen, the DLCO is hard to obtain, right? So you can't rely that much. If they have connective tissue disease and they have Raynaud's, it's very hard to rely on the pulse oximetry. So it's not one test that helps you decide solely whether it's pH or not.
I think you said something, Jean, I just want to pick up on. You said you can't be right all the time.
Right.
But I think that we've got to change that narrative because it's not right or wrong. And if we send patients for a right heart cath and they don't have pulmonary hypertension, doesn't mean we did something bad or incorrect.
Exactly, right.
Because the way I present it to the patients is, gosh, you have pulmonary hypertension, that's bad news, but the good news is we can treat it, we can potentially make you better. You get a right heart cath, there's no pulmonary hypertension, the glass is still half full. You don't have pulmonary hypertension, you have a better prognosis, so that's good. We'll continue to follow you. So it's never wrong to get a right heart cath.
That is very true, and I think we're sometimes scared of right heart caths in patients on supplemental oxygen that have lung disease, but it is a very safe procedure done in the right hands, and it has such an impact on outcomes. So let's look at our information. The biggest thing that popped out for us was the DLCO and the heart rate recovery, and that ratio is clearly greater than 1.5 when you look at the FVC percentage versus the DLCO percent. So the other thing that we might have noticed on the CT chest is the pulmonary artery is greater than the aorta size, something else that's a little window into what's going on in the right heart. And the BNP was elevated. So we had a few things that were driving us towards high-risk features for pulmonary hypertension. And then if we can add that to what data we glean from an echocardiogram, we can then justify our going on to right heart catheterization. And this, if you want to take a picture, it's, this is a nice article that gives you some kind of framework to see these individuals and plug them into an algorithm that's expert-driven. So, echocardiogram, estimated pulmonary pressure is above 75. Left atrium, which is very important in our older individuals, is normal size. When you have a severely dilated left atrium, you have to think that the pressures maybe are coming from the left side of the heart, but normal left atrium. So reassuring me that this is not a left-sided driven process. And EF is mildly decreased at 42%, so something we have to be mindful of and make sure we take that into account when we evaluate the patient. So we get our right heart cath. Are you guys surprised by the right heart cath? Mean of 30, sorry. Right atrial pressure of 2, PVR 4.5.
Not too surprised, quite impressive.
Yeah.
In fact, it looks like the patient's probably slightly dry, and so the pressures would probably be higher if he got tanked up a little bit.
If you drink a few glasses of water?
Yes, you kept him waiting for the cath too long,
Exactly.
and he's been NPO for 12 hours.
And I made him take his diuretics. So, what do you think about this gentleman? Heart failure, venous thromboembolism, infection, or do you think, check, this is the real deal PH-ILD? All right. So, do you guys agree?
Yes, we
Yes.
do.
Okay.
Yeah, for sure. I'm looking at one person who put infection.
I think they're just keeping
I
us
think
on
they
our
just want
toes.
to challenge us.
Exactly.
They want to keep us on
That
our
was still
toes.
impressive. Impressive answer. Anytime you're above 90%. Okay.
So how do you want to treat this individual? Is this somebody you want to talk about inhaled treprostinil, ambrisentan, riociguat, PDE5s, or none of the above? All right.
So just put
Well, I think that everyone agrees on inhaled treprostinil. What about my experts?
Oh my gosh.
Yeah.
Wow. Yeah. No dissenters. Yeah.
Does this person fit in what would have been included in increased trial?
Yes,
Yeah.
definitely.
Yeah.
PVR 4.5. Yeah, for sure.
So, oops, going back to
I think
Yeah.
I think we, in the interest of time, we did have another case, but I think we were
Yeah.
overly ambitious. I think we need to go through that.
Okay,
Yeah.
okay.
Yeah.
So just a little bit of guidance on who to treat, who not to treat, and this person had a lot of features of the people we would tend to offer treatment to. Advanced symptoms, high PVR, that ratio that we were looking for, BNP, low DLCO, so helping us to lean toward the fact that maybe this patient is having more symptoms related to their vasculopathy. So with that, would you like to do that?
Well, now we want to open it up for questions. We want to respect that everyone wants to get over to the main meeting, and we have just over 5 minutes left. So why don't we open up to the audience and see what folks have to say or to ask.
Yeah, and we can do raising hands. We have a microphone. We have a question over there. Are you going to?
We have these blinding lights on us, so I can't see who has questions, but there's someone walking around with a
Can
microphone.
you bring the microphone over there, please? Can you? Yeah, perfect. Thank you.
Hi, thank you. Great talk. My question is, after when you have somebody with advanced ILD as well as signs of severe PH, and you do start them on the inhaled treprostinil, but then they don't really have significant change in symptoms or change in hemodynamics, what would you suggest is like the second step or the third agent before you consider, or they don't qualify for lung transplant, and sort of in that intermediary group where they're uncomfortable, but you don't want to also say like, well, okay, this is the end for you?
That's a very good question, because that does come up. What I would say is that aside from the improvement in walk distance, there are downstream benefits of inhaled treprostinil, less hospitalization, the suggestion that there's less mortality, so, and other things as well. So if they don't feel better, it doesn't mean to say that the drug's not doing something. But you bring up another very important point, and this is where referral to a PH center becomes important, because they can have more severe pulmonary hypertension and what we would regard as, well, maybe a PAH type of phenotype. And we're certainly guilty of that ourselves. I think we all are, where we put them on more aggressive therapies like parenteral prostanoids. So, you know, and that depends on the severity of the pulmonary hypertension, especially in relation to the ILD. And there is some data to suggest that parenteral prostanoids, for those who have more severe pulmonary hypertension, might be of benefit, but not approved for that indication, and so that would be off-label, but I think we're all guilty of that.
Yeah, certainly in severe cases. The other option is, and that goes to the referral to the PH center, clinical trials. Now that we have one therapy, then there's a lot of interest in developing other therapies or newer therapies for this particular group. And there are a lot of ongoing clinical trials that these patients may be able to participate.
And I think the other thing to remember is sometimes patients don't feel like they're getting better, but then you show them their echo. You might redo a right heart cath. You show them the trend on their oxygen or their walk distance, and you say, but these are objective parameters that look like you're getting better. So I think don't give that one away.
A last point before this question, sometimes stability is good as well. Sometimes I see patients who are in clinic, I say, come back and see me in 3 months, and I think they're not going to be back. And they come back. And then I see them and I think they're not going to be back. And they come back.
We have a question up front
Go
here.
ahead.
Great job. Thank you so much. And where does BMI fit in this? Do we have those patients that are obese, and how do you interpret some of this data in somebody who's with a higher BMI?
Very good question,
One of you want to take this?
Well, I think we can kind of break it up in different parts. Be careful of using BNP as a marker of stress on the heart in patients who have an elevated BMI, because sometimes it can be attenuated.
Right. Or, on the other hand, if they have metabolic syndrome, they may have left heart diastolic dysfunction, and the BNP can go up because of that. So you have to put, the other thing is, when you do the right heart cath, you want to make sure you measure the wedge and all the pressures at end expiration, but not forced expiration. If it's in a very large individual, end expiration creates positive pressure, so then you have to compromise and get average pressures in the respiratory cycle variation. So they pose a little bit of extra challenge.
And sometimes, just with regards to that last point, if the wedge is elevated, I don't do the caths myself, we have excellent cardiologists who do it, but they know if the wedge is 17 or 18, please get an LV EDP, let's see what that is, and then you can use the LV EDP as well.
That's another way to do it, And also look at the left atrial size. That's why an echo is also important.
Definitely.
I see a hand up over there.
We have a hand over there.
Again, thanks for a great talk. You guys often mention that patient with mild pulmonary hypertension, and certainly those individuals, I think Gene brought up 1920, you talked about your patient with a mean pH of about 24. My question in that patient cohort is, where does an exercise right heart cath fit into your armamentarium of diagnostic workup to define those who may have a different hemodynamic phenotype?
Ioana, you want to take that?
Yeah, sure, absolutely. We do a lot of exercise caths. So if the pressures and the hemodynamics are already abnormal at rest, even if they're mild or severe, it doesn't matter. I'm not sure how much more the exercise cath brings us. What it can tell us what's the immediate limitation. Is it the vascular disease that limits, that brings the patient to the anaerobic threshold, or is it the respiratory gas exchange problem? But in the end, I'm not sure if, from the treatment perspective, it matters. What we do in the cath lab with exercise is, if the pressures are normal, that's when, or the upper limit of normal, and our clinical suspicion is the presence of pulmonary hypertension, that's when we exercise them with hemodynamics. But for clinical practice, if the pressures are already abnormal at rest, I'm not sure how much more it's going to bring me as far as decision making.
I guess the one thing would be if you're worried that they could have a bigger component of diastolic dysfunction, if you're trying to sort that out.
Yes, but they're very difficult to exercise, these patients. If you think about left heart disease, and it's from practice to practice, my recommendation is to do a fluid challenge because it's easier. 500 cc's of saline over 5 minutes, so a rapid infusion, 5 to 10 minutes, to see if the wedge is going up.
All right, well, we're at the, I was going to say the top of the hour, but it's the bottom of the hour, 7:30 exactly. We want to respect everyone's time to get to the main meeting. I think we've come to the end. I do want to thank you all for hanging out, for your engagement, my great colleagues. I think it was a great interchange, and thank you all very much. Enjoy the rest of CHEST. Thank you.
Excellent. Good job.